Hello, this is Andre, and today I'm going to discuss Impetigo, and this lesion is a part of my lip lesion series. Impetigo is defined as a highly contagious superficial bacterial skin infection, mostly endemic of tropical countries, and is primarily caused by Streptococcus pyogenes and Staphylococcus aureus. It is most commonly seen in children, but it can occur in adults as well. It is more prevalent, as I mentioned before, in warm, humid climates and during the summer months. It is easily spread through direct contact with infected lesions or by sharing personal items such as towels, clothes, or toys. The outbreaks are common in settings such as gyms, daycares, and schools. Impetigo is classified into two main types based on its clinical presentation. One, the non-bullous impetigo, also known as Impetigo contagiosa, and second, bullous impetigo. Now let's just focus a little bit on non-bullous impetigo. This is the most common form, representing about 70% of all the cases, and it is what comes into our minds when we think about this pathology. It is characterized by this honey-colored crust on a red base. It forms because we have some small vesicles that are filled with fluid. When they rupture and they ooze, that dry ooze, to call it that way, form the crust. On the other hand, bullous impetigo is the less common form of this pathology and is characterized by large, full-fleet blisters that may rupture, and instead of leaving a crust, they leave a scaly base. It is more often associated with Staphylococcus aureus infection. And since I'm talking about vesicles and blisters, what is the difference between the two of them? Okay, so a vesicle is defined as a small fluid-filled sac that typically measures less than 5 millimeters in diameter. The blisters are defined as a larger fluid-filled sac, usually measuring more or over than 5 millimeters in diameter. And lastly, if we talk about transmission, the Impetigo contagiosa is more contagious due to direct contact with the lesion and their exudate. Eruption and crust formation. This toxic production and epidermal damage caused by the exotoxins that I just mentioned before are the ones that are going to cause direct tissue damage. After this is when we're going to find the vesicle formation. On the non-bullous type, the vesicles are going to rupture and then they're going to release the exudate that they have inside. And this is what is going to form the honey-colored crust. And it is until we have this direct contact with the lesion or the contaminated surfaces that the infection starts to spread. Lastly, neutrophil infiltration is going to lead to inflammation and crust formation. The healing is going to happen without any scarring, but in this case of the non-bullous type, this bacteria can trigger post-streptococcal glomerulonephritis. On the bullous type, basically the only difference is that these exotoxins, ETA, ETB, are going to target the desmoglein 1. Desmoglein is like this type of protein, this glue that held the cells together. And this is going to cause epidermal cell separation. Therefore, the blisters are going to expand with this toxic mediated acantholysis. And once that happens, the process is pretty much the same compared to the non-bullous type. If we compare the clinical signs and symptoms of both types, we can see that the non-bullous, remember, is the one that usually pops into our mind when we think about this pathology. We see that the vesicles that quickly rupture are going to ooze for a few days, and then they're going to form this honey-colored crust. The patient may complain of some itching and soreness. And in the bullous impetigo, these big blisters are going to arise from this erythematous base, and when they rupture, they're going to leave a moist, scaly base rather than the honey color crust that we see on the other type. Diagnosis is based on the characteristic clinical appearance. A culture of the fluid from the source may be necessary to identify the type of bacteria that is causing the infection. In management and treatment, what we need to highlight the most is that the patient and their family members, they need to highlight hygiene measures. So we need to encourage proper hygiene, including regular hand washing, avoid scratching the area, and gently lesion care, like cleaning gently with soap. Topical antibiotics are also prescribed, and they need to be applied directly to the lesions for those mild and localized cases. And oral antibiotics are recommended on those big cases or when the topical treatment fails. The prognosis is usually excellent with proper treatment, and the lesions typically heal without any scarring within 7 to 10 days. However, some complications such as post-streptococcal glomerulonephritis can rarely occur, especially in those cases that are associated with Streptococcus pyogenes infections. The differential diagnosis should be the impetigo should be differentiated from other skin conditions that cause similar lesions such as herpes, contact dermatitis, and eczema. And now some common questions that we might have regarding impetigo. 1. Can malaise occur before an impetigo outbreak? While this feeling is not typical, it's not a typical symptom of impetigo. In some cases, really rare cases of a widespread infection, and in those like people that are really vulnerable, a mild systemic symptom such as fatigue, fever may occur. Second, how can impetigo can be distinguished from herpes labialis or cold sores? So we need to remember that impetigo usually presents as this honey colored crust after the vesicle ruptures. By cold sores involves a painful clusters that evolve into ulcers, and then we have without the characteristic crust that we have in impetigo. Herpes or cold sores usually have those prodromal symptoms, and impetigo does not. We might also ask ourselves, are there any patient populations more vulnerable to impetigo that dental professionals should be aware of? Yes, children, immunocompromised individuals, and those with pre-existing skin conditions are at higher risk. Can impetigo affect intraoral tissues? Yes, but it's extremely rare. And lastly, how can a differential diagnosis be made when impetigo mimics other oral conditions? So first, a careful clinical assessment is required to differentiate impetigo from other conditions, such as angular keratitis or candidiasis. In these cases, bacterial cultures can assist when lesions are atypical or unresponsive to initial treatment. And one last thought. How do you think should dental professionals approach a patient with suspected impetigo? I think that we need to postpone elective treatment and refer for medical evaluation. It is a safe thing to do for us, for our dental team, and for our patient. If you love this information and you find it useful, please don't forget to like it, comment, share it, and save it. Bye bye.